What were some of the demographics or profiles of the patient groups that were studied?
It was pretty inclusive. So in the study that was run, the Optimum trial in the UK, we really had a broad coverage of the country. There were 39 hospitals involved. Many of them were community hospitals. So we can really say this is not just, an inner city selected population, but there were many patients from rural areas. There were unfortunately, also in the UK, we have quite a large, population of relatively deprived areas. We have actually ethnic representation of ethnic groups actually in the UK. I think myeloma happens in some populations a bit more commonly, but overall, I think the most relevant thing is that we have in the past often seen patients from deprived areas not really being represented. And I think in this trial, they have really been able to take part, and we have seen a success of that treatment across the board.
Are there specific genetic markers or chromosomal abnormalities that are now considered maybe definitive indicators of high risk myeloma in the new guidelines at all?
Yeah, there is. It's actually a complex disease, and the genetics are complex equally. So there are mostly large changes of chromosomes.
Mm.
So there are chromosomal translocations. Um, they often co-occur or happen at the same time as well, with parts of the genome being lost or additional gains happening, so chromosomal deletions or gains. And these are the commonest changes that one finds in myeloma. And the worst actually groups are those where several of these co-occur, where they just accumulate these damages over time.
Mm.
Um, there are also, as we call them, point mutations, single nucleotide variants in some very aggressive genes like TP53. But what we also found is that additional tests such as gene expression profiles tell us patients that we can't identify even with the most refined genetic tools. And these patients, it's a similar situation to breast cancer. It's also somewhere where you can find and diagnose patients better when you actually combine different tests. It's the
Mm.
same in myeloma.
And in thinking about this array of tests, what are your thoughts on the disparities in access to advanced genetic testing tools
Mm.
across different healthcare systems? How do we, you know, is there any strategy for this for different resourced systems?
Yeah, it is a challenge, and I mean, I think it will still be a certain inequality or a difference in access that we will see over time, because of course it needs normally countries to some extent invest in their infrastructure, or healthcare systems to invest in their infrastructure to get the diagnostics better. I think it's a big step forward, of course, that we have a better guideline now that actually motivates and really recommends that. I think it makes it easier in systems that have insurance companies to really make the claim or the case for that these patients need to follow the guidelines to full. I think overall, we do see, of course, this happening in many oncological cancers, that the diagnostics are getting more complex, but also actually help us personalize treatment. And that's ultimately what we do if we treat high risk patients differently. We're personalizing treatment in myeloma, and it's an essential part of oncology care. So I think it's something that over time will hopefully only improve.
Mhm.